We are going to switch gears and talk about sarcoma. Dr. Pretell is first up. He's going to talk about outcomes of unplanned excisions of soft tissue sarcomas.
Hello. So thank you, Roy and Derek and the International Department for putting this together. It's a very good opportunity to listen to all these new things that are happening now in orthopedics and also to, not so new, but always interesting to listen is these topics about tumors. Guys, from you, who do you have the chance to see like soft tissue masses, sarcomas in your practice? Do you have a cancer center there in America? No. Okay. Do you have access to different adjuvant treatments, radiation, chemos? Yes. Okay, good. So, what type of multidisciplinary approach do you use? Do you have tumor boards, or is kind of press a phone call? Okay, good. Okay, so okay, so that's good. I mean, ideally, you know, this patient should be treated in general in big cancer center with big volumes in order to have, you know, the optimal outcomes. But you know, you can do whatever you can to help these people. So this topic of unplanned excisions, it's something that I have been working with since I started my career, like 11 years ago. I have no disclosures. So that is a patient I saw when I was in fellowship. That was my first patient that I saw with an unplanned excision. Funny fact is that he was very happy because the surgeon found that he had a tumor. So that's something that really caught my attention because it's something that, you know, when you do these unplanned excisions, you potentially can have very bad outcomes, oncological outcomes. But then you have to deal with the psychology of this patient that loves the surgeon that referred to me. And you cannot say anything, you know, bad about the surgeon, but also you are kind of frustrated because now you have to deal with a very complex problem. So this guy, 58-year-old male with pain and swelling in the right upper extremity. The short story is that he was lifting some heavy weights and felt like a pop. So initially he was diagnosed like a tendon tear, right? So he went to the orthopedic surgeon and, you know, tendon tear, blah, blah. They did that CT and you can see, you know, you can see some like a mass effect there, right? But it was, you know, interpreted like a hematoma. And so they decided to repair the tear and drain the hematoma. And they went in, they started draining, and drainage was not really blood. It was a little bit funky with, you know, solid pieces. So then they decided to send it to pathology, and it came as a high-grade sarcoma. But what you can see there are different things. So how they close the wound, very wide sutures. All the hematoma that was left after. And then here you can see the blood. So we see the lateral aspect, not even in the same, you know, line with the cell. So, you know, they did several things that were not correct. But then, well, they referred to see us, right? So this was a case that kind of introduced me in the topic. And after the day of clinics, I went to home, and I started looking in the literature to see what was there. And there were a lot of different, you know, articles, but there was not like something together, like to say, okay, let's see if there is a review article or something like that. And there was nothing at that time, and so we decided to write the first current concepts that was published in JBS in 2015. So this was a patient that introduced me into the topic. So this, this topic is not new. The term unplanned excision is already known since the 80s. The basic concept is a tumor resection without preoperative diagnostic modalities, or if they have the modalities, the interpretation is not correct. And the intention when they do the surgery is not to achieve any free margins because they don't know that they are dealing with a sarcoma. Now, the problem is that these sarcomas are very rare and is unsuspected, so there is not an adequate evaluation of these patients. And remember that benign tumors are much more common than this. So the assumption, the human assumption is to say, oh, this is a benign tumor, this is a lipoma, whatever, or a hematoma, right? And then you fail and you're surprised that it's a sarcoma. So who are involved in this type of surgeries? Usually plastic surgeons, general surgeons, and unfortunately orthopedic surgeons also. So several studies have reported that these unplanned excisions represents about 18 to 66% of new patients referred to sarcoma centers, and that's something that I can attest. That, for example, this case is a patient that was seen by a hand surgeon outside, community hand surgeon, and so he saw this patient with that mass, right? He did an MRI. I mean, he has suspicious of what is this, but the report of the MRI came as a schwannoma, right? So he kind of okay, it's a schwannoma. Then he opened this, removed the tumor, sent it out. It was a high-grade sarcoma, and that's a particular thing, right? Because our teaching, classic teaching, is okay. Big tumor, more than 5 centimeters deep, down to the fascia. Suspect this is a sarcoma, but also sarcomas exist in the upper extremities, superficial tumors, and even like you can say up to 30% they can be sarcomas within the sarcoma group, right? So then we have this problem, right? I go to the office and then I'm surrounded of these patients, right, with all these unplanned excisions, and then I have to do what I say a backwards workup, right? Because here the patient comes already with the tumor out, so I have to go back like a puzzle and try to see what was done and start gathering information to see what's the best treatment approach. These patients, regarding the age, will be the same as patients with sarcoma, mid-50s, is the same profile. History of trauma, so this is important because in general, right, many patients with soft tissue sarcomas will have a history of trauma, some kind of trauma. You ask the patient, hey, do you have a trauma? Oh yeah, 20 years ago, I fell from my bed. No, something more recent. Oh yes, I had this. And that's human nature. People will try to explain why they have a mass. So the easiest thing to do is to say, okay, yes, I had a trauma. So regarding the size, right, these tumors, these patients with unplanned excisions usually will have superficial tumors, small tumors, upper or lower extremities. Most commonly, probably upper extremities. The other thing is that the most common misdiagnosis, right, in these patients will be either a lipoma or a hematoma, right? The problem is that, for the lipomas, many times, a lot of physicians, they only touch the patient, they see, oh, you have a mass, probably it's a lipoma. And probably they will be correct. I mean, because lipomas are much more common, but they don't go further and they don't do not even an ultrasound or an MRI, right? When you're thinking about a lipoma, doing an MRI is very easy, and you can diagnose that without a biopsy or anything like that. So, but sometimes they don't want to do that extra step, and they leave it like that, and then there is a problem, resection is not a lipoma, it's a sarcoma. And the other thing very common, hematomas, right? And the problem is that the high-grade sarcomas, they can bleed inside. So they will look like a hematoma. So then you have to go a little bit more into the history of this patient and say, okay, this patient had a trauma, right, that can explain the hematoma. If this patient has any blood dyscrasia, that can explain spontaneous bleeding. This patient is taking any anticoagulation treatment, that can explain this bleeding. So you have to kind of go a little bit more deeper in the history of the patient to see if a hematoma can be explained or not. The most common pathologic diagnosis will be, so this is a study that we published in 21, and you can see the difference in planned excisions. The most common sarcoma is the UPS, no, undifferentiated pleomorphic sarcoma, or also is called myofibroblastic sarcoma. And then in the unplanned excision is the myxopharosarcoma, right? And that tumor is a little bit of a problem because it's very aggressive locally. It grows in an infiltrative pattern, very difficult to resect with negative margins. So you can imagine if, to the fact that I have a tumor that is really a problem to resect as a planned excision, if you add the additional contamination that you can create with an unplanned excision, then it's a big problem for local control. Now, regarding the classification of these procedures, you can have, total unplanned excisions is where nothing is done, right? And the surgeon goes, boom, remove the tumor. And the partial unplanned excisions, right, where some kind of workup is done. You can do an MRI, you can do ultrasound, you can do something, trying to see, or even a biopsy, right? But the problem is that everything is malinterpreted. The biopsy is not reviewed by a MSK pathology, so you have an inadequate diagnosis. The MRI, even though it's read by a radiologist, then they also get a bad, a bad interpretation. So then you have, to be depending on other specialties that they should be correct in order for you to have a good, information and a good decision making. So that's why it's important that even if you have some suspicious for a soft tissue mass to be a sarcoma, really don't go, deeper on that and trying to refer to a specialized center, because it will be a much, faster intervention in the patient. So when you have an unplanned excision, what I like to do is to ask 3 questions to myself. First, what was done to the patient, right? And that's the detective game that I was talking about, to try to build a puzzle. Then, what is going on with the tumor, right? Locally and systemically. And lastly, when I have all that information, then I can ask myself, what should I do at that point? So the management following an unplanned excision should be done in a multidisciplinary approach in a sarcoma center. The treating team should gather operative reports, right, to see if there were multiple masses removed, what approach was used, potentially what tissues were affected, diagnostic imaging that was done before the resection, pathology reports and histology slides. That's super important. Okay, there is Lord Randall from UC Davis. He published a few years ago that up to 37% of the diagnoses were incorrect. So if you start your treatment with an incorrect diagnosis, then you have an incorrect treatment, right? So first thing, pathology reports, histology slides. Those should be reviewed 100% of times. And then you also have to ask about any treatment that the patient could have before, right? More resections, maybe they start some kind of radiation or chemotherapy, whatever. But you have to know exactly what was done. Then, of course, start with physical exam. No, go into and see the surgical site. Very important to see the skin incisions that were used. Usually, transverse or oblique incisions are a problem because they cover much larger surface. So then your resection will be much bigger. That can compromise the lymph function. Also, it can end up using more complex procedures for closure, like muscle flaps, local flaps, free flaps, tissue rearrangement, etc. And also, the radiation fields can get wider because you have to cover much more surface of contamination. Also, you have to see the hematoma, presence of hematoma, because this potentially can increase the contamination beyond the area where the tumor was. And the use of drains, basically to see if they were trespassing other compartments that they should have not trespassed. Finally, skin closure. It has to be done, by layers to reduce the dead space and as thin as possible, to trying to have less resection area. Regarding the tumor, what is going on with the tumor? For that, we do what we know as staging of the tumor, right? Or the patient. So a local staging, the minimum we have to do is an MRI, right? To see how is looking the surgical bed, right? If there is any macroscopic tumor left, or there is only post-surgical changes that can indicate that there is some microscopic tumor that was left there. And distant staging, at least a CT of the chest, at least. Depending on the type of sarcoma, then you can do further workup, CT chest, abdomen, pelvis. There are some soft tissue sarcomas that are more prone to have other metastases, other even bone, right, like the myxoliposarcoma, that it can go also to the bones. So for that specific soft tissue sarcoma, you have to order MRI of the spine, for example. But it will depend on a case by case. This is a case of a pleomorphic myxopharosarcoma, post-unplanned excision. That was a tumor, right? And then they did the excision. And in that case, there was microscopic tumor that was left that we saw in the tumor bed after the resection. The problem with the imaging studies is that they are not as accurate to tell you if there is tumor or not. There are some articles, right, like the ones that you can see published there, but you can see that the sensitivity of this MRI really goes down, like around the 60s, 70s, in order to detect, residual tumor. The other problem is that these tumors also can affect, right, the oncological outcomes of these patients, and you can have increased local recurrence of the tumor, but also in some centers it has been described that you can have decreased overall survival, even though that is not totally accepted as an outcome in this type of procedures. Regarding the treatment, you have three things that you can do: the tumor bed excision, which is a re-resection of the surgical bed. You have radiation and chemotherapy. The radiation and the chemotherapy follows the same principles as for the planned excisions. Regarding radiation, we usually use the protocols like if it was pre-op radiation. Even though you already had surgery, the protocol that we use is like a pre-op radiation protocol. And that's something that is used, across all institutions. The tumor bed excision, the goal is to remove residual sarcoma, either macroscopic or microscopic, and potentially the contaminated tissues that are around with negative margins. The rationale for this is that there could be, gross or microscopic residual disease, and is often present following unplanned excisions, which has prognostic implications. You can see there, that's a table that from the current concept that we published a few years ago, and you can see that there is a high percentage of re-resections that have tumor present on that tumor bed, right? So there is always, tumor that is left on the surgical site. Regarding the treatment, the surgical treatment, there is two approaches. Here in the United States, and I think almost all over the world, except French people, we are very aggressive with this, and we do re-resections. Okay, so that's kind of the gold standard for this. However, you can see those two groups. One is from Italy and the other is from France. That they try to do the wait and watch approach, meaning that, okay, you have there, you don't see really, macroscopic tumor, no? So then you wait and see if there is a recurrence or not. The problem with that is that, there is literature saying that when you do that, when you have the recurrence, then potentially you can have implications with a worse overall survival. So then that's the question, right? I mean, if we wait, then it will recur, and then potentially the patient can have worse overall survival. So that approach, is a little bit more complex to follow. These studies say the same thing. 5-year overall survival. You can see the local, if there is local recurrence in the group of local recurrence, the 5-year overall survival will be lower. No? So there can be that impact. Tumor bed excision has been found that is an independent predictor for local control, right? The tumor bed excision should include resection of prior operative incision, inclusion of adjacent cuff of skin and soft tissues based on operative report, pathology reports, physical exam, and MRI. The adequate surgical resection is difficult in this case because of the presence of a scar, loss of normal anatomical planes, and many times when there is microscopic tumor, you really are not touching the mass. So it's kind of, you are kind of blind, to do those resections. And we published also this article regarding the accuracy of intraoperative assessment when you are doing these re-resections. And we found that, in a center with a specialized MSK pathologist, you can have a very good accuracy in detecting residual tumor and evaluating the margins, very similar to planned resections. And that's important because if you find, positive margins intraoperatively, then you can do a re-resection at that time. And that can save, trips of the patients again for re-resections later on. The other question is, okay, I have this patient that had surgery, 1 month ago, and when should I do the surgery? In reality, there is not too much research about that, the optimal time to do this re-resections. This study is the only one I have found by hand, and they didn't see any difference in local recurrence rate regarding the timing when you do the surgery. They divided their group in 2 groups, 32 days, like the cutoff. They didn't find any difference. The question of the $1 million is how much should be resected, and I think that if you see in the upper right hand side, that's a very good, nice example. Nerds get into the internet, go to surgery.com, scroll down, and click on "Are you totally lost?" No? And that's sometimes how we feel, because you don't have tumor palpable, you have an MRI with a bunch of edema, a surgical site with a drain, going to different compartments, and you're like, how much should I resect? In that sense, some authors, they recommend 2 centimeters, 3 centimeters of margin around what you believe it should be the contamination on an MRI, no? But in reality, there is not a good answer for that. And as a consequence, right, because you are doing these massive resections, then these tumor-bed excisions are very morbid, right? And it has been shown in previous studies that the need for flaps, skin graft, local flaps, free flaps is higher, right, in these cases. So it's very important when we have these patients to have a very good relationship with plastic surgery in order to plan, the coverage, the closure of these in these cases. That's another important issue, when to close this patient, right? Now I am a little bit more careful, and I probably almost all the cases of unplanned excisions, I do stage closures. I do the resection, send to pathology, and wait for margins. In the meantime, I use wound back systems. And then when I have a negative margin in pathology, then I coordinate with plastic surgery to close the patient. But also, not only will have impact on the patient itself, but also in the health system, because these cases also are more costly. Patients stay more in the hospital, so everything is a little bit more expensive when this happens. And you can see there in that article that plastic surgery is important, because you can have in these cases skin defects that are larger in the unplanned excision, and also the need for, as I say, for more complex closures. This is a recent systematic review and meta-analysis that we published 2 years ago, and this is the largest study published on this topic. 16,949 patients included. Of those, 6,017 unplanned excisions, 35%. More or less, that's kind of the epidemiology on these cases. And you can see there that, for example, plastic surgery reconstruction, it's important. I mean, there will be a higher need for plastic surgery reconstruction in those cases. And this is the study I was talking about, the cost, right? Patients with unplanned excision will have more surgeries. It will be more costly, the management, and the hospital stay also will be longer. Radiation, it has not, really, we don't understand really well how much the radiation what's the role of radiation in these cases. However, in most recent studies, it has been seen that preoperative radiation improve the local control in these cases. So in my practice, I usually try to do preoperative radiation in these cases, and then do the re-resection. No? So more or less, these last 3 articles that I show you show more or less the same control rates with preoperative radiation in the 90%. However, there will be some patients in which you cannot do surgery because it's too morbid, and you can try to do only radiation, and it has been seen that the results are acceptable for those cases with local control, which that is pretty good, as you can see in this article from Mass General. However, it's a little bit old. It's from 2005. Chemotherapy is the same protocol as the management for planned excisions. Chemotherapy basically is used for high-risk patients for metastatic disease, patients that will have tumors more than 5 centimeters deep and high grade. Regarding the prognosis, the 5 years local recurrence-free survival will be affected by the unplanned excision. It will be decreased. The 5-year overall survival, we didn't find a difference on overall survival in these patients. However, there is the group from Toronto with Jay Wander that they have published one big retrospective study, like with 500 patients, and they found that there was decreased overall survival in those patients. And also from the same group, they published another paper recently with small soft tissue sarcomas that are superficial, and they also found that unplanned excision was affecting the overall survival. However, they are the only ones that have found this. So I don't know if Canadians have a different problem than us. Residual disease at 5 years, local recurrence-free survival is also affected by unplanned excision. So that's the proof that we were talking about, that why that wait and watch approach can be a little bit dangerous, because if you wait for a local recurrence, potentially the overall survival of the patient will be affected. The 5-year overall survival in recurrence of disease also will be decreased, right? So that's the importance of trying not to have a recurrence in these cases. Now, regarding amputation rate, it has been published in the literature that usually these unplanned excisions will have a higher amputation rate. However, we, in our systematic review and meta-analysis, we didn't find that difference. So, it will depend a lot in case by case how much, morbid you have to do the resections. So in conclusions, these unplanned excisions are still a significant problem and volume of referral to us. The best way to approach is with prevention and education, trying not to have these unplanned excisions done. The tumor-bed excision is the standard of care. Radiation nowadays is moving towards neoadjuvant radiation in these cases. Chemotherapy, same guidelines as planned excisions. And basically the oncological outcomes that will be affected will be local recurrence, 5 years local recurrence-free survival, and the overall survival and metastatic disease probably is not affected in these patients, and is more dependent on the grade of the tumor rather than the procedure itself. Thank you.
All right, I hope you guys are in the mood for more talk on sarcomas, because Giovanni Paraliticci is going to talk about diagnosis and treatment of soft tissue sarcoma.
Okay. Good afternoon, everyone. Last but not least, okay. I know you guys have been here all day. It's kind of tired. I will try to be as brief as possible. I want to thank Dr. Ribas, Maria Vila, and the entire group of Baptist Health International Group for having us today, and to share our experience and our passion of what we do on a daily basis here at Baptist. So as I said, I'm Giovanni Paraliticci. I'm an orthopedic surgeon. I specialize in orthopedic oncology and also in total joints. I love complex and big cases. So why is this topic is important? Everyone here in the room has a family member, a friend, or even a personal experience dealing with cancer, some kind of tumor or malignancy in our life. This is a condition that does not discriminate, doesn't matter gender, doesn't matter race, doesn't matter any social economic status, anything. So someone in our life is going to be affected by this condition. It's a rare. There are multiple subtypes. Less than 1% of the entire cancers in the world that are diagnosed are related to sarcomas. And in the pediatric population, it's less than 7%. Talk a little bit about, there's two types of sarcoma. There's bone sarcomas. Primary bone sarcomas are extremely rare. The most common type are osteosarcoma, Ewing sarcomas, and chondrosarcoma. The most common malignancy in the bone is, however, metastatic disease. And then we have the soft tissue sarcomas, which is a cancer that is derived either from the muscle, tendons, cartilage, blood vessels, or any fibrous tissue. As per the American Cancer Society from 2024, 14,000 cases were diagnosed in the United States. That is very rare compared to other cancers, but it's increasing in frequency. More common in male now than in females, and 5,200 are expected to die from sarcoma in a year. As Dr. Pretell mentioned in his talk, benign conditions are more common than malignant in a ratio of 100 to 50 to 1. And as per 1 million people in the United States, 20 of them will have a sarcoma. So that tells you how rare it is, but we're going to encounter there, especially in a specialized institution. Dr. Pretell mentioned this as well, the most common soft tissue sarcoma in a planning scenario is in undifferentiated pleomorphic sarcoma, liposarcoma, and leiomyosarcoma. Common in the extremity, lower extremity twice as more common than the upper extremity. These conditions are mimicker. So you think you can have an infection, you think you can have, as Dr. Pretell mentioned, a trauma, which will bring it to the attention of people. But it's not. You're trying to come up with excuses like, why have a lump there and it's been growing over the last weeks or years, depending on the type of cancer or tumor. A little basic concept, kind of Dr. Pretell mentioned, but I'm going to kind of play it as simple as possible. Sarcomas, we talk about it, but adjuvant treatment and neoadjuvant treatment. What's the difference? It depends on the type of cancer. Neoadjuvant treatment refers any chemo radiation that is given prior to surgery, and then adjuvant therapy is chemo radiation after surgery. Okay, and then radiation. What happens when we give preoperative radiation or postoperative radiation? In sarcomas, after we discuss our cases in the sarcoma tumor board, there's a consensus from our multidisciplinary team, and we provide the recommendations that we understand as per the clinical guidelines are the best for this type of tumor for our patient. And in the preoperative setting, there's a higher risk of wound complications. The recurrence rate is pretty similar from pre-op to postoperative radiation. It can be given now in a hypofractionated manner, meaning you don't have to wait the 12 weeks, which was the standard time that was given back. You can give it in 3 weeks, a dose of radiation. So in total dose, you get less amount of radiation. In the setting of postoperative radiation, it's going to be a larger field. It's going to be a larger dose of radiation, and this is going to increase the complications such as fibrosis, stiffness, and most likely edema. Chemotherapy. When do we recall or try to use the role of chemotherapy as per recommendation? Mostly are in the setting of a tumor that has a potential to become systemic. Those tumors that are big, that are deep to the fascia, greater than 5 centimeters, or a high-grade tumor, those are the ones that we normally recommend to undergo chemotherapy. And the type of chemotherapy is an agent-based protocol that is given to the patient. I cannot emphasize on how important is the history and physical examination. You'll be surprised about how many patients will walk into your office and say, "Doctor, you're the first one who's really touching this mass and examining me and seeing how I move my arm or my leg. No one just touched it before. They just say, oh, you have something there, go get the study, and then do the surgery." So it's imperative that we need to examine the patient. With the physical examination and the history, you can get the diagnosis or a differential diagnosis in about 60 to 70% of the time. And then we combine that with imaging modalities, and we combine also with a biopsy to try to get a diagnosis or a differential diagnosis. Don't get fooled that painless mass, because painless mass may be both benign or malignant. Questions that I like to ask the patients: how long have you had that mass? Is it growing rapidly? Is it growing slowly? Did you ever had any history of any accident, any history of radiation, any prior history of cancer, any family history of cancer? Is it painful or not? Is there any unintentional weight loss, any fever, any night chills? Even though these are classic signs and symptoms of some kind of malignancy, they don't happen in all the patients. So we always have to be aware that any mass that we encounter, we should always think that is a malignant. As Dr. Pretell mentioned, this is a classic interpretation. Any deep mass greater than 5 centimeters that is very firm to the fascia is a concern for a malignancy. But the superficial mass, a third of them may be benign. So the rest of them, the 67%, may be malignant. So bear in mind and remember that, please. We combine the examination with transillumination, if there's history of trauma, if there's any shooting pain, is there any improvement that help us kind of start making our differential. And if there's any regional lymph nodes, there's certain type of sarcomas that they spread out to the regional lymph nodes, and this is a concern for malignancy, such as synovial sarcoma, angiosarcoma, epithelosarcoma, and some like that. I get asked this question very often in the office. Doctor, is there any blood work that can tell me if I have cancer? And the question is, there's not 100% specificity for a cancer, but there is some suggestion that they may be associated with some kind of tumor or some kind of cancer. Molecular testing, I don't know, they asked ChatGPT and we'll give it the answer or not, but tumor markers nowadays, like PSA for prostate, help you guide your treatment and kind of be indicative that there may be some prostate malignancy, such as in the alpha-fetoprotein for liver, okay? But it's not only one blood test or one specific test that will tell you you have this type of cancer. You need to combine it with other modalities. And then that's when we also add the images. And then the most simple one that we forget about, X-ray. Most of the time, I will get a patient with an MRI and not having an X-ray. I don't know how that happens, but it happens. We can tell a lot from the X-ray. And like in this X-ray, it's something that is quick and inexpensive. You can see a heavily calcified mass around the left hip. So that tells you this doesn't look benign. This looks like angry looking. So that is suggested that something is happening there. Okay? And there's some other examples that we see here in the far left. It's a skeletally immature individual with a soft tissue mass in the forearm and some round calcification. So that kind of lets you know this possibly may be a hemangioma, okay? This image in the middle, you see a heavily mineralized mass in the back of the distal femur. That doesn't look good either. So that may be an extraskeletal osteosarcoma. And then the far image to the right is an x-ray of the elbow in a patient with a history of trauma, and you see that calcification anteriorly. So you kind of start putting pieces together and say, maybe this may be like an myositis ossificans, okay? But again, you cannot diagnose these conditions entirely with one image modality, okay? And then you combine this with the gold standard, which is MRI. And then MRI will help you. It's very sensitive. You add contrast to this, and it'll help you distinguish if the mass is solid, is it cystic. It can help you also guide for the treatment, for the needle biopsy, for the core needle biopsy, which is the area that will be more sensitive to provide us with the diagnosis. And in the case that patient has a recurrence, it can help us distinguish scar tissue versus recurrent disease. Okay, so all of this is to help us decrease the amount of what Dr. Pretell was talking about, unplanned excisions, and try to coin the best diagnosis for the patient. Some patient will come with an ultrasound. It's very easy to get, is cheap. However, the ultrasound is very dependent on the person performing the study. So unless you have a very skilled sonographer that can help you provide a lot of detail of the mass or that is in question here, then it was not going to give you too much information. But if you have a skilled sonographer, you can help distinguish a solid versus cystic mass. You can see the area that has more flow, and this can also guide you for a biopsy. And the very skilled ones can help you tell and distinguish a recurrence versus scar tissue. Patients that are unable to undergo an MRI have CT scan, and we also obtain CT scan for staging studies. The staging studies are performed, as Dr. Pretell mentioned, for CT scan of the chest, and in certain cases also at the abdomen and pelvis. PET-CT. PET-CT is a very modality that is jumping into attraction in the centers of cancer. However, it's a very expensive tool right now, and it's not indicated for all the sarcomas unless you have a baseline study. This will help you first for staging in certain conditions and also help you identify if there's any kind of recurrence, and especially in a patient that had a radiated field. And you can also see the response the patient underwent treatment, either radiation or chemotherapy, okay? But it's very expensive, and it's not every patient is as easy to get. And there's certain kind of sarcomas, such as myxosarcoma, that they're not useful to have this study. So after we have all the studies, we got the biopsy, and we try to identify this in the multidisciplinary team. if there's a sarcoma, but if not, if the biopsy comes back positive and the image is suggesting for positive and the history and the physical exam suggesting for positive, so then we know it's a benign tumor. Then we can proceed by removing this mass with a marginal resection. And if it's a malignant condition, then we present this case in the tumor board, and then we have the multi-D team together to try to give the best the best option for treatment of the patient and avoid what Dr. Pretell was talking about, having a patient with an unplanned excision. I want to take a minute for this. People think that biopsies are simple, and the reality is not. There's a lot of complications that can happen to biopsies, the patient undergoing biopsy, especially the person performing the biopsy is not clear about what is the track to do, where to take the sample, okay? Back in the days, a lot of biopsies were performed open, but hematoma contamination led to a wider surgical resection. And there's a big study from the University of Miami that Dr. Pretell was part of it that evaluated core needle biopsy versus open biopsy, and they found that there was no significant difference between one and the other one in terms of recurrence. So less invasive core needle biopsy, and that's our gold standard now. But a good study from the Musculoskeletal Tumor Society in which they evaluated centers that were specialized in oncology and patients that were not specialized in oncology, and they found that the centers that were not specialized had almost a 20% chance of complications. That led to 18 patients undergoing amputations that were not necessary. So that tells you that this is important, to have a skilled pathologist have to perform a biopsy by a specialized person that knows what they're doing, and have the team evaluate this tissue. And it was 12 times better results for the patient if this procedure was performed by an orthopedic oncologist. So better outcomes for those patients. So these are examples of the type of resections that we perform in our oncology world. Benign tumors, you perform like a piecemeal fashion, but we perform a en-bloc resection, okay? So you have to go throughout the reactive zone. You don't have to remove a covered normal tissue. Malignant version, you do remove the mass covered with normal tissue around it, and you got to make sure that the tumor is completely surrounded by normal tissue and nothing is exposed. And in the case that there's a contamination, then we have to be more radical and remove a compartment, including vessels, bone, soft tissue, anything that's involved. After we remove it, benign lesions are 99.9% of the time closed primarily. And then there's the stage closure that Dr. Pretell mentioned. We use a lot of the plastic surgery in our institution because these are not small incisions. These are not small surgery. This is like big surgery. And then most of the time, our preferred method is to do a delay wound closure. So we remove the tumor, we put we mark our margins, and then we place a wound back. And after that, we await the final pathology to make sure that the margins are negative. And once our margins are negative, the patient comes back in a week or 10 days, and then we perform the final closure if it's amenable for us, or if not, it's performed with plastic surgery. So in conclusion, we have to follow a guideline. We have to make sure that every patient that we encounter with this is treated the same way, so that way we decrease the chances of error. Patients should be referred to a tertiary institution, which are specialized in orthopedic oncology or musculoskeletal oncology, to decrease the chances of complications. Benign lesions are more common, as we mentioned, but not all tumors are benign. And we should recognize this malignance and refer them. We need to obtain the necessary images before we perform a surgery in our patient. And we need to combine this with our multidisciplinary team so we can provide our patients with the higher, not only oncological outcome, but with the highest functional outcome. I'm just going to go briefly over some examples. This is a 59-year-old female, as you can see in the MRI in the top corner up. It's a large mass involving the proximal thigh. She underwent a biopsy. It was a pleomorphic spindle cell sarcoma. Presented in the tumor board, the consensus was to undergo preoperative or neoadjuvant radiation. As we can see here, how this is unfortunately after radiation, she got burned in her skin. So that's how wide we have to go. We got to make sure we have some margin that we can avoid contaminating or spillage of this tumor around the wound. So this is how it looked after we remove it. It's a big defect, as you can see. So it was so large that we didn't feel comfortable with the margins, so we placed a wound back, and we awaited for final pathology. Once they confirmed it was negative, the margin, so Plastic came by and closed it. This is another case of a young gentleman, 51, who had this mass in the leg that had been growing. It became very painful for him. He had a biopsy. It was a pleomorphic myxofibrosarcoma. These tumors are very tricky. They're very infiltrative. And as you can see in the MRI in the top and lower, it basically involved almost the posterior compartment of the leg. We presented on tumor board. The recommendation was to undergo amputation, but the patient was adamant about having amputation. He did not want to leave without his leg. So then we proceeded to recommend radiation and then salvage. This is how it looked after radiation. That's how huge the mass was. The lower part is the knee. The ankle is on top over there. And the next image, that is how after removal of the posterior compartment of the leg. And then that's the tumor over there covered with muscle. And then it was a stage closure by plastics. This is a young gentleman, 36-year-old male, who had a mass in the medial aspect of the distal thigh and the knee, growing for 2 years. It was a high-grade liposarcoma. He was presented at tumor board. He started with neoadjuvant treatment. Unfortunately, he was not responding to treatment, so we had to stop the treatment and then proceed with surgery. As you can see, the extent of the tumor from medial to lateral, and all the part of the skin is out from where the tumor was fungating. The knee is down here. And then we placed a wound bag after we removed that. And this is how it looked after it was removed. And then plastic came and finalized the closure. And range of motion is not great. It's from, I would say, from 10 to 80 degrees. But the patient is happy. He's able to go back to work and move around, and he has his limb. This is the most recent case that I did with Dr. Pretell here. It was a transfer from Homestead Hospital. Unfortunately, this is a male with a very large mass. That is the posterior aspect of the shoulder. The elbow is down here. And this is the shoulder on top. This mass has been growing 15 years. Unfortunately, it was neglected by the patient and the family members. And it was fungating. It was bleeding, fetid odor. It was diagnosed as a melanoma. So in order to provide, the patient was advancing and progressing, losing blood. So we did a resection of that huge mass. That was the large defect that was left behind. This is the scapula here, scapular spine. Okay, this is medial and that's lateral. We placed a wound back as well, and we awaited final pathology. So we just got notice that it was negative this past Friday, so plastic is going to go and close it down. That's about it. Any questions? Thank you for your time.
Any questions? Sir.
Procedure, if any of these doctors would like to maybe present the case to tumor board with you for consideration of a case, minimums that you would require to present to tumor board, maybe even before surgery, MRIs, et cetera. Can you please expand? And how can we access tumor board from afar for those that are listening also?
Yes, so we have our tumor board committee. Patient will require to have the pathology, the slides. We need to see them by our pathologist. We need the necessary imaging studies, an MRI, and some staging studies, such as a CT scan from the chest, and then have the slide, have a history of the patient. Sorry, and then once we get together, get all the data together, then we can coordinate and have presented in the tumor board.
Any other questions? I have a question for you, Gio. What is the time, the turnover time for path? So after you resect that tumor and you're waiting for negative margins to the time where like some sort of soft tissue coverage occurs, what is the typical time?
It varies by the type of tumor.
Okay.
But I would say average, what, 10 days? More or less? 10 or 14 days.
10 to 14 days. Got it. Got it.
Question. What do you consider an adequate core needle biopsy specimen?
So, depending on the images, and depending on the area where the tumor is, let's say, for example, you have a mass in the upper medial thigh, and you're not, the biopsy principle will tell you that you cannot go from lateral to medial to get a sample, despite that area being there. You have to go to an area where you plan where your surgical incision is going to be accordingly. And not only that, you need to look for the area that is more metabolically active. So that's going to give you the highest yield for the pathology. Usually the pathologists here are good with 3 or 4 core from a 19 gauge needle. So that's, if you look at it from your finger, and it's like a 2 millimeter or 2 thickness, and then they can take that to the lab.
Piggyback question for the same
let
thing.
me finish with this. So the other thing that should be done is to, whenever it's possible, is to do frozen. So when you take the a core, then send it to frozen to see if it's diagnostic tissue. And also use the use of ultrasound also is important, because there are some tumors that are more cystic than solid, and then with the ultrasound you can identify solid areas where you should target the cores. No? But it's important to have to be able to have diagnostic tissue, to be sure that you have diagnostic tissue, because if not, then the typical is non-diagnostic, and then you have to again the patient try to reach out to him, and the problem is that many times these pathologists go outside for second opinions. So if you have a non-diagnostic tissue, then you can either repeat, or maybe the pathologist of your center will send it to second opinion, and then time is running there. So at the end of the day, you repeat in the biopsy 3 weeks after the first biopsy, and it's a vicious circle of timing. No?
I think you answered my question already. I was about to ask if you need to repeat a biopsy, what is the consideration of a frozen section on table? Frozen section biopsy on table.
Oh yeah, I mean that.
That's the one you're answering.
But also, regarding repeating biopsies, there is all years before, the gold standard was open biopsies, right? Nowadays, we're shifting to core needle biopsies. Even though the theory is that open biopsies you can get more tissue, etc. I mean, there are several studies that shows that there is similar accuracy, diagnostic accuracy with core needle biopsies. The problem is that in those cases where you have non-diagnostic results, then the question is, what should you do, right? If you have to repeat corneal biopsy, or you go to an open biopsy. In those cases, it's important to maybe have a discussion in your multidisciplinary group and see what will be the best for the patients. In my practice, I don't think it's a mistake. If you have a non-diagnostic corneal biopsy, I think you can repeat another corneal biopsy, making sure that you target solid tissue. If it continues to come negative, then or no diagnostic, then you can maybe try an open biopsy. But the problem is that usually in those cases of non-diagnostics are the cystic ones that have a lot of necrosis. So in those cases, when you're trying to do an open biopsy, also you can explode the tumor. No? So it's a little bit messy. So it's another issue that you should discuss with a multidisciplinary team, to have the best outcome for the patients.
All right, I think we're going to wind that down.